The current UK population incidence and prevalence suggests that it is the commonest male cancer diagnosed currently. One of the problems that we face in primary and secondary care is that the reality is that for many men the symptoms of prostate cancer are pretty much the same as the symptoms of benign urological disease that we treat on a daily basis. For example, a change in the frequency with which they pass urine during the day and at night, a change in the quality of their perception of how fast they pass urine when they pee, the presence or absence of hesitancy, and terminal dribbling, which is a consequence of where it's difficult for the man to stop the flow of urine. Blood in the urine is an occasional symptom of prostate cancer, but generally speaking isn't particularly common. Frequency and urgency in combination can certainly be a presenting feature of prostate cancer, although again it's certainly the case that non-cancer diagnoses can present in a similar way. We get most concerned about men who present with a combination of urinary symptoms with other systemic symptoms such as weight loss, back pain in particular, which can sometimes suggest the presence of bone metastases, as can hip pain. But one of the problems is that, unfortunately, because of that overlap between the symptoms of benign and malignant disease, there's very little specificity to any particular urological symptom that helps us out in that regard. Clearly, some men are at a higher risk of having an underlying prostate cancer diagnosis than others, and those risk factors are important for us to be aware of when faced with a man presenting with a concern about a prostate cancer diagnosis. The most significant risk, which most people are already well aware of, is age. Family history is a significant risk factor for some men. If an individual male has a first-degree family relative, so that's brother, father, uncle, who've been diagnosed with prostate cancer early in their life, then that individual man's risk factor for himself is doubled of prostate cancer. If that individual has two first-degree family relatives affected by prostate cancer diagnosed early in their life, then the increased risk for that individual man is tenfold higher. So family history really is a very important part of our assessment of these men. Ethnicity is an important consideration. So we know that Afro-Caribbean men have a higher risk of more aggressive prostate cancers. Hematospermia, surprisingly to many people, is actually rarely an indication of an underlying prostate cancer diagnosis. The significant majority of men presenting with hematospermia will have a benign underlying explanation for that. And generally speaking, they are less of concern to us as urologists than individuals who present with hematuria, blood in the urine. Erectile dysfunction is a very common phenomenon in men as they get older, so we see a proportion of men who present with a combination of urinary symptoms and sexual dysfunction who might turn out to have an underlying prostate cancer diagnosis, but in itself is not a specific indicator either way. So as you'll be familiar with, one of the diagnostic tests that can be helpful in diagnosing or indeed excluding prostate cancer is the PSA blood test. PSA stands for prostate-specific antigen because it's a protein. It's a normal protein found in seminal plasma. There's a huge quantity of it in terms of concentration in seminal plasma, and a small amount leaks into the bloodstream, so therefore we can detect it on a fairly standard venous blood sample. Currently in the UK, a PSA value of 3.0 or lower would be considered normal in a man between the ages of 50 and 59. For men between the ages of 60 and 69, a PSA of 4.0 or lower would be considered to be normal. And for men over 70, a PSA of 5.0 or lower would be considered to be normal. Clearly, laboratory ranges vary quite significantly, so it's important that we're all familiar with the normal range represented in our own laboratories. Population screening with PSA is unhelpful in respect of prostate cancer earlier diagnosis, primarily because so many men with an elevated PSA level will not have prostate cancer. So as a rough guide, in men who present with a PSA between 4 and 10, only around 25% of those men will actually have a prostate cancer diagnosis. And indeed, with a PSA of 10 or more, still only around 50% of men will have a prostate cancer diagnosis of clinical significance. What we do, however, is encourage the use of PSA in what is termed case finding. So clearly, if a man turns up in your surgery as a primary care physician with lower urinary tract symptoms, it would be very sensible to have a conversation with that man about the place of PSA in assessing the potential significance of those symptoms. Even more important in men with a significant family history or any of the other significant risk factors. I think it's important to bear in mind that there are certainly men in whom prostate cancer is diagnosed who have an elevated PSA. We also see men with a normal PSA who have prostate cancer. And from time to time, we do encounter men who have a clinically significant prostate cancer detected who have a lower than normal PSA value. It is very likely that for most of those latter men that reflects the poorly differentiated state of an aggressive prostate cancer in which PSA secretory mechanisms are abnormal. A normal digital rectal examination will, generally speaking, not affect PSA levels, and therefore you can comfortably and confidently include a digital rectal examination in your clinical assessment of that patient, in the knowledge that it is very unlikely that that would impact significantly on that man's PSA level. If one encounters any significant palpable nodularity or asymmetry, then that should certainly raise one's suspicion and potentially encourage the consideration of referral on a 2-week wait basis. I think it's important at this point just to touch on NG12. The current advice suggests that men who present with any level of suspicion of prostate cancer pertaining to an abnormal digital rectal examination or with regard to an abnormality of their PSA that's out with the age-specific normal range should be referred for assessment on a 2-week wait basis. Following receipt of a 2-week wait referral, that individual will be seen and assessed in terms of their clinical history, often using validated symptom scores. They'll have a physical examination, including a digital rectal examination, a combination of 2 investigations, a multiparametric MRI scan, an underlying tissue diagnosis will also be required. Generally speaking, that will take the form of an outpatient transrectal ultrasound guided biopsy of the prostate, performed under local anaesthetic and with appropriate antibiotic cover given both pre-procedurally and following the procedure in order to reduce the risks of post-biopsy bleeding and sepsis.